Good afternoon. Good afternoon. Good afternoon. Good afternoon. Yes, you are on for the mental health panel here at Calvary Baptist Church. I am so excited. I'm your host, yours truly, Pastor Hosea of CBC of Hawthorne, and we have an amazing lineup today. I am so super excited about what we're getting ready to get into in these next few minutes. I'm going to open us up with a word of prayer. I'm going to give everybody a few minutes to come on and log on. And also, like this video and share this video and let everybody else know that we're on. Mental health is a very serious subject matter in our community. We all deal with mental health. Yes, I said we all. Lottie Dottie, everybody. None of us are exempt from dealing with mental health because that's just what it is. It's your mental health. The same way you have physical health, you have mental health. And we know we're on a 21-day holistic fast and consecration here at Calvary. So with that being said, your mental is a part of the wholeness of you. For we are spirit, soul, and body. You are not just what you see when you look in the mirror. You are a spirit, you have a soul, and you live inside of a body. So it's very important that we take care of all three of those components: spirit, soul, and body. Your spirit is your God connection. That's who you are as it relates to in the image and likeness of God. So your spirit makes you God conscious. Your soul, however, makes you self conscious. Your soul is your mind, your will, and your emotions. And this is the area where we make decisions, where we process, where we really live in this area. This is the steering wheel to your life. And then, of course, we have our bodies, and our bodies is where our spirit and our soul is housed. We live in this vessel called the body. So our body makes us world conscious. Our soul makes us self conscious, and our spirit makes us God conscious. So today we're going to be focusing on the soul because that's where our mental health lies: mind, will, and emotions. So at this particular time, I'm going to get ready to pray us in. Again, like this video, share it with others. And we're dealing with mental health from every aspect. Because when I say mental health, people think I ain't crazy. This is not about being crazy. We've got to rid ourselves of that stigma. I'm not crazy. I have mental health issues. There are times when my mindset isn't right. There are times I may find myself thinking the wrong thoughts and allowing my mind to get caught up on circumstances and find myself being depressed. There are times we lose loved ones that are close to us, and I find myself being extremely sad. There are all of these. This is mental health. This is your mental health. And then, yeah, we have some more severe cases where a person may have a diagnosis, whether that be a bipolar disorder, or schizophrenia, or things of that nature. It's all mental health. And I'm glad you're tuning in today because we're going to deal with this problem. But more importantly, we're going to deal with solutions to this problem. Let me remind you, if you would like to ask a question anonymously, you can do so by emailing that question to calvarymentalhealth@gmail.com. Again, that's calvarymentalhealth@gmail.com. And we will address that question leaving you anonymous. Now, also, if you're in the comment box, you can type in a question while we're live, and we will address that as well. So feel free to ask, to learn, and to share this video with someone else. Let them know they can log in because I promise you today, you will receive answers. Even if you have a family member that's dealing with mental health and you don't know what to do about it. Well, I have some experts on with some answers for you today. So I'm excited about it. Let us pray, and I'm going to introduce our other panelists. Father, in the name of Jesus, we thank you now, oh God, for your grace, for your mercy, for your loving kindness. Thank you for this mental health panel, and thank you, oh God, for blessing us with this knowledge, this wisdom, this information, and this platform to have conversation, because we recognize the fact we learn from one another. Iron sharpeneth iron. Lord God, each one of us make one another better. We help each other to grow and to evolve and you didn't create us just to be independent. You created us to be interdependent. So we thank you, right now, oh God, for allowing that to manifest itself in this platform, in this hour. So let this be a blessed panel. Let none of us leave the way we came, but let us all leave more informed, more empowered, and more wise. In Jesus' name. Amen. All right. With that being said, let's introduce our first panelist. You all know her very well. I thank God for her. Not only is she a member of Calvary Baptist Church, I'm excited to call her a friend. She is a very professional young lady whose God is blessed to be in my life for many years now, and my life has been enhanced thereby it. The greatest gifts you receive from God are not materialistic. They're meaningful relationships that enhance our lives for the better. So she's one of those gifts. With no further ado, you know her. She works as a public defendant right here in Los Angeles, California, and she is really fighting the good fight. She's on the front lines dealing with injustices every day in a real way. She's not part of the problem. She is part of the solution. And with no further ado, help me welcome our very own Sister Cheryl Bailey, Esquire.
Hey, Pastor Hosea. Good morning, Calvary. Well, good afternoon. Oh, you are so sweet. You know, I love you. And I love the fact that we can just laugh and educate at the same time. So I'm very excited about today. I'm very excited about our guests. So let's get to it.
All right, let's get to it. So let me bring on someone that may be new to many of you. She's not new to ministry, but she is new to this mental health panel. So for the first time, I want to introduce this awesome woman of God. She's a primary mental health nurse practitioner. Yes, she is. Board certified by the American Association of Nurse Practitioners, and she's currently licensed to practice in the state of California. She began her career in nursing in 2010 and has been a primary mental health nurse practitioner since 2018. Her previous experience includes work as a registered nurse in the emergency department for 8 years. She's qualified to diagnose and treat a wide array of mental health conditions across the entire lifespan. She's a graduate from California State University, Los Angeles School of Nursing, undergraduate Grand Canyon University, Phoenix, Arizona School of Nursing, and a certificate from American Association of Nurse Practitioners. Help me welcome at this particular time the one, the only, my sister, my friend, Dominique Griffin.
Hi, Calvary. Hi, everybody. How you guys doing?
Wonderful, wonderful, wonderful. Glad to have you on with us today to offer your expertise. We know you're on the front line every day, every week, dealing with these issues and helping our people overcome. So, for that, I want to say thank you. We owe a great debt of gratitude to all of our healthcare workers.
Yes.
And you definitely qualified to receive that gratitude. So, let me start by saying thank you.
Thank you. Thank you so much for the introduction. Thank you for having me. I feel very, very, very happy to be here. So
Wonderful.
Yes.
So let us start. Let us start. So we're gonna dive right there in as we
Okay.
talk about mental health, and I want to start because it's been a few months, Cheryl, since we had this particular platform. We had to get through the holidays and things of that nature, but here we are. I think our last one was in November, if I'm not
Yes.
correct.
And we were dealing with grief at that time.
We were dealing with grief and getting through that because the holidays, I know, was a rough time for many of us, considering our lost loved ones. But I wanna start by just kind of reminding people to kind of attack this whole stigma of mental health meaning crazy. Oh, and our people have a problem with that word sometimes because of the stigma attached to it that you're crazy. And I was trying to address even in our introduction, we all have mental health. And let me tell you what's crazy. You ready for this? You want to talk crazy? I'll tell you what's crazy. What's crazy is for you to be dealing with mental health issues and not try to get no help. That's crazy.
Yeah,
That's crazy.
I
To
agree.
to be suffering in silence while there are people here that's more than qualified to help you get control of that, to overcome it, to get victory over it. But now let's get to Dominique specifically, because I understand you really do deal with the full scope. You see people with basic mental health issues, is having a hard time just coping with life, and you see people with more severe medical clinical mental health issues that you have to deal with. I've always wondered on how do you really assess, because I think sometimes some of us may actually maybe need some form of medication as we're trying to get something under control, but we're rejective of it all. We worry about the stigma. Want somebody to think us crazy. How do you determine one from the other? Someone who's just having a rough time psychologically and someone that really needs some more severe clinical assistance in this.
So first, it's typically a inpatient, outpatient. So if there's patients that are outpatient that I'm seeing, a lot of times, to start off, those patients are typically more stable. And when I say stable, meaning they'll just, maybe they're suffering from maybe clinical depression, but it's with maybe somewhat in remission. They still have the symptoms, but you're able to treat them adequately without them being hospitalized in an inpatient setting. And then you have the inpatient setting where a patient, the difference between the both, where let's say, for example, if a person is is saying that they're suffering from depression, but then they start saying that they're having suicidal thoughts, uh,
Okay.
that would be an indication for me to say, okay, well, how do you feel about going into the inpatient setting? Because even if you're having thoughts, it doesn't necessarily mean that you won't act upon these thoughts. So my thought is always, it's always safe and, be safe than sorry, especially if they already have a history of, trying to attempt to, harm themselves. And then maybe their environment may be toxic. So it's a variety of factors that determine whether or not if a patient is probably on that sketchy side of being, not so stable to where they can just, follow up with just medications, maybe some therapy, and they'll be okay, versus a person that, maybe a family member or a loved one could possibly pass away, or they'll have a rough time at work and they're already on that gray line. Why take the chance and allowing that person to just, stay at home? I will prefer them to come into an inpatient setting. So it's a variety of factors, but it's always looking at the background history, possibly their environment, how they deal under levels of either stress. Are they open to taking medication? Some people, like you said, it's a stigma. They're very, when you think, this is something, was discussed not long ago. When people think of mental health, unfortunately, the stigma is people think like stray jacket or white jacket, are the old movies where
An
people
asylum.
sit in those electric chairs with the electrodes attached to their head, and it's unfortunate. I mean, but that's what you think of when you think, for some people, when they think of mental health, they say, oh no, I'm not crazy, I don't need that, it's nothing wrong with me, but yeah, so it just depends on the person, but it's really about, in my assessment, really sitting down, getting to know their background, how they handle certain things. Are they open to medication? If not, maybe intensive therapy, so and then drugs, alcohol. So it's a variety. It's a big picture on how you're treating someone. I call it an art. So it's an art.
Yeah.
Yeah.
Well, I know from my experience on the patient side, it took a long time for me to really identify. I've been diagnosed with generalized anxiety disorder and severe depressive disorder. And it took me a long time to even identify, because I worked 3 jobs. I was going to school. I looked like somebody who had all of their stuff together,
Yeah.
but I had behaviors that didn't make sense. And people didn't know how to identify those behaviors. So like, I can go out to the club with my friends and we'd be partying and having a good time. And then something would just happen and I'll be like, I have to go right now. Right now. We have to all go. Leave. We have to leave right now. And I would make everybody leave. And I was like, I'm just done for the night. And that's what I thought it was. I didn't know it was anxiety.
Yeah.
All the people were getting to me and I couldn't identify it was something that was triggering this behavior.
Mm-hmm.
And so I think what a lot of people need to see when talking about diagnoses, I think it might be helpful to know what are some of the common diagnoses that we see in our communities that people can look out for, outside of anxiety and depression, because I think we all kind of suffer from that. It's clinical when it becomes, like you said, interfering with our jobs and our lives. And that's when it became clinical for me. And at work, I was having one of those days where I was hiding in a friend's office because I just could not deal. And she looked at me and she was like, you don't have to suffer.
Wow.
Mm-hmm. Wow.
And that's what Pastor Hosea was saying. And I was like, wait, what do you mean? She was like, you weren't made to suffer. You don't have to suffer through this.
Yeah.
And I was raised to, you pick yourself up and you go. No matter what happens, if you break your ankle, you get on crutches and you still go. But she was like, no, that's not how it works. You don't have to suffer. God did not make you to suffer.
Is that what led you to get help?
Huh?
That's what led you to go and seek?
That was the very first time I ever thought about getting help.
Wow. Wow.
Because she told me I didn't have to suffer.
That's amazing that she even, said something. That's a good friend.
Yeah. So I think it would be helpful for people if we can, just talk about some of the very common diagnoses that you see in the community.
Okay.
And just, very basic definition of what those things are and what they look like.
Okay. So I see, of course, in addition to the most common ones that we won't really, we'll put it like this, we'll intertwine it with some of the diagnoses because they overlap sometimes, but most commonly I do see schizophrenia. So schizophrenia is under the lines of, there's like 2 categories. It's like psychotic type of behaviors or psychotic diagnoses, and then also there's mood disorders. So under the psychotic diagnoses, schizophrenia will be one of them. And schizophrenia is typically, like, we look at whether or not if they're having hallucinations, and that can be if they're hearing things when other people aren't around. And I'm not speaking of like if you're hearing things, because it's very common for people to kind of like hear their own self like talk as they're moving through life. Like, okay, I got to do this. I'm not speaking of that. I'm speaking of you actually hear a voice that does not sound like yours, and it is telling you to possibly do certain things, which we would consider to be commanding hallucinations, Or we typically look at delusions, where some people are very delusional. They feel that the most common one I see is where people feel like others are conspiring against them. They feel that people are out to attack them. The Illuminatis, they tell me the cartel is trying to attack them.
The FBI.
The FBI, and some people feel like that the president of the United States has we call it thought insertion, where the president is telling them specific things about COVID-19 and how they're the savior of COVID-19. So like those type of things, like all clustered together, is normally 2 or more within a certain time frame. That will be considered to be schizophrenia.
And
Now,
what's the age onset of schizophrenia? So people can.
Yeah, so we get to that, the early onset of age of schizophrenia. It starts off, those are like more of the positive symptoms, where when you see that, you're like, okay, yeah, that person's schizophrenia, they're talking to themselves. Sometimes you typically see, for some people, on corners of certain, different places, and you'll say, oh, okay, they're talking to themselves, they're hitting the walls, they're schizophrenic. Okay, but we do have it where the early onset sometimes doesn't really show like that, and it can be children. I've seen ages, the earliest I think I've seen was probably about 9 or 10 years old. Sometimes earlier than that, where they don't necessarily have those voices, like the positive signs that I talked about, like the delusions and the hallucinations, but they'll have more of the negative symptoms of schizophrenia. And so that's where a lot of, I feel like, parents, or guardians should be educated about that, because it really presents as a child being by themselves, kind of isolated. Maybe a parent will distinguish it as, oh, okay, they're an introvert, but the reality of it is that these are beginning signs and symptoms of them being schizophrenic. And so they'll do poorly in school, their communication skills aren't really there. It To make it very simplistic, it mimics major depressive disorder. It looks like a child that doesn't have the energy, not doing well in school, just maybe have negative thoughts. We consider it to be, I don't know if you've ever seen someone where their affect, the way that their facial expression is really flat. No sense of smiling. If they're upset, no facial expression of being upset. Like, so those are like symptoms where we would consider it to be negative if you see in a child, and those normally present in a child early onset. And then as they get older, sometimes they have triggers. Sometimes it can be a stress load. I've seen it where a 17-year-old had an extreme amount of stress load with school, and all of a sudden started to hear voices, and people think, oh, it could be genetic. It can be a trigger of drugs, so it can be so many things, but those are the early signs that typically present where people will get misdiagnosed. And if they're seeing a therapist, sometimes the therapist may say, oh, they're just coming out of it, or it's just maybe it's a divorce between the family members. But you have to really pay close attention, because if it's a pattern, then it could be, not, you may not need excuse me, you may not need medication necessarily beginning onset, but if you're intensive with therapy, you're really, being around that person, trying to talk to them, a lot of times you can help them from jumping into like that full-blown positive, signs and symptoms of schizophrenic, if that makes any sense, because there's a lot of people that are functioning schizophrenia. Well, and that's just one diagnosis, but yeah. So then there's bipolar is also another diagnosis I frequently see, but that will be considered under like the mood, right? Because bipolar, if there's 2 different types. There's a bipolar 1, where a person is completely manic and they will have like the symptoms that are, I mean, quite obvious, where they're very impulsive, they're very hyperactive, all of a sudden say, hey, I want to go shopping, probably have maybe $200 in their account, and then they'll overdraft however much. And then the next day, they'll probably go out and just eat, and maybe they're diabetic and they're not supposed to eat certain things, but because they're so impulsive, the world is, they're just, it's a never ending thing. They're very grandiose, where they they think like, they're at the top of the scale. Like, and I have certain patients that I can say that are very, they're bipolar 1, and they feel like they're the president of the United States. Like, they say and do whatever they feel without any indication or thought of any consequences whatsoever. So that's like one thing that I typically see with bipolar. And then they have a bipolar type 2, where that's more of like a depressive kind of up and down, where a person could be like kind of hypomanic, which basically means that they're grandiose, they're impulsive, but not that quite. It's kind of like, if you could think of it, just think of it as like in the middle, where they'll go and run off and do certain things. I've seen people become very impulsive, like sexually, and they'll probably sleep with like 7 people in 1 week or something like that.
Wow.
Yeah, and that's part of it, because they're very impulsive. Their thoughts are racing. They have a flight of ideas, consistently thinking, yeah, I'm going to go and study for this. No, I'm going to go and do that. And and they're going, their speech is rapid. They're just, consistently going on and on and on and on. They frequently interrupt people. Like, they're just nonstop. So that's kind of like the hypomanic, and then they have the depressive type. But that's I try to like put it in somewhat of a closed door, where I see bipolar and schizophrenia. I would say another common one, it's unfortunate, is drug induced type of like a psychosis, where a lot of times it's methamphetamines is what I predominantly see, but it can be, cocaine. It can be maybe they're withdrawing from alcohol, because when you withdraw from alcohol, it's like, what I always think of it like, what goes up must come down. So if you're drinking and that side effect, you're just kind of really, you're drunk, you're passed out. Some people are functioning alcoholics, but when they start to withdraw from the alcohol is when a lot of times they could become extremely psychotic, and they start to hear voices. And you can kind of, that's where the fine line is, where I said it kind of overlaps, right? Because then you're saying, are they schizophrenic? But it's like, no, that if they consumed alcohol, that is, if they're having auditory hallucinations after the fact, then that is because of that reason, because they're withdrawing, and that is a withdrawal symptom. But but the meth-induced psychosis is very unfortunate. I would say, because I've also practiced at an emergency department, and what I see typically is, out of, let's say if I see maybe 10 patients, I would say maybe out of 8 out of those 10 patients have used methamphetamines. And it's very common.
I also notice it a lot at work too. And it's always a game that you're playing. Is it meth or is it schizophrenia? Or did the meth cause a schizophrenia? It's like, what came first, the chicken or the egg? Right. It's like, you don't know, because a lot of times people use drugs. And tell me if you see this too, Dominique, that they use drugs to self-medicate because they do have a mental health issue. Like, some people can be suffering from anxiety, depression, schizophrenia, and their drug of choice, because it makes them hyper or whatever, their drug of choice is alcohol because it brings them down. Or meth is also a big drug of choice for people who are suffering from bipolar or schizophrenia, but then meth also causes psychosis. So it's hard to, like, so if you see kids or an adult that is engaging in a lot of substance abuse, that may be a signal to you that either one, they may be self-medicating because of some mental health issues,
Right.
or two, that's also a trigger for you to look out for mental health issues because of the substance. Would you agree
Right.
with that?
Yeah,
Wow.
absolutely.
That's crazy.
Absolutely. I typically
Wow.
you can't the thing about it is that it's you could treat, like you could try to isolate the diagnosis, right, and try to figure out, is it this or that, but a lot of times if you're treating for what the signs and symptoms are and also what their background possibly is, right? So let's just say if they have been a methamphetamine abuser for years, and even though they're hearing voices, the questions that I always ask is, do you hear voices maybe inside your head or outside of your head? Are they consistent, or they broken up? And so those are like the type of questions that will kind of lead to you finding out, okay, this is a drug induced type of well, not schizophrenia, but a drug induced psychosis, because schizophrenia would be, if they really are a schizophrenic. But if they're just psychotic, there's a diagnosis called brief psychotic disorder, where they have never experienced anything at all, and all of a sudden they start hearing voices, but then after a month, or less than a month, it goes away, and then it never happens to them again. So it's like it's a brief, it's a brief psychotic disorder, and it could have been from drinking too much, it could have been from using meth, whatever it might be, but it just happened. Doesn't mean you have schizophrenia, but it was a brief psychotic disorder. But a lot of times with those patients, what I see, and it's like I said, it's really unfortunate, is because when anyone uses especially meth, they have like these keloids a lot of times in their skin, and then when they're withdrawing, they're very shaky, very, very shaky, like a shake that is almost I like to probably like define it where it's similar to a person having like mild like seizures, because they're really shaky, and it's almost as if like, what's going on, but you realize like, okay, this is a withdrawal symptom from something that has like really caused them to go up, like where it's like something in your neurotransmitter called dopamine, where so if your dopamine level is like really, really, really high, and a lot of times if you're coming down from that, like with cocaine, all of the uppers, you can have those symptoms. You can have those symptoms, and that's where it gets, like you said, I'm sure it gets tricky, because you're trying to distinguish, okay, is this a drug induced psychosis versus is this an onset of schizophrenia? So
Wow.
We have a question. We have a couple of questions.
Sure.
Yeah.
Number one is, can a child trauma cause a mental health issue?
Yes, absolutely.
What kind of issues do you generally see outside of anxiety and depression? Because I know those are probably standard.
So I see gender dysphoria a lot with children, where it's possibly some type of trauma that they were exposed to at an early age, maybe molested. A lot of times I see if they were sexually abused, there is a very fine line between sexual abuse, and then in addition to possible gender dysphoria, or of course, it's the trauma, the post-traumatic stress disorder. But yeah, I see that a lot. Also, what else do I see with kids? Attention deficit hyperactive disorder. So they'll have ADD, and that also, I think you and I were talking about that as well too, Cheryl, where it's a fine line between a kid bouncing off of the walls, can't sit down, just very hyperactive, versus too much sugar. If you got too much sugar, you need to quit giving your baby so much sugar. Okay. Just
let's start there.
Every Black kid does not have ADHD. Okay. Let's start there. Right. But there is real ADHDs. Somebody asked a question. It says, what about multiple personalities? Have you seen that?
Yes.
Multiple personality disorder?
Absolutely. I actually saw that yesterday morning at one of the hospitals that I was at, where it was a lady that was, just talking regular, and in the midst of her talking, she started to take upon this voice of a man and started to act like a man. And I was kind of like, oh, wait a minute, what just happened? And I mean, she literally went from talking, as the elderly, sweet lady telling me about, what was going on, to within a split second start speaking like a man. And started telling me how, she felt that others were conspiring against her. So yeah, multiple personalities, definitely. I also think that that's like the classic ABC, right? But then there's also
What's the
where
classic ABC? We don't
the
know.
classic ABC is what I just explained. Like, you'll see this 1 minute, then you'll see the next. And that's but to be honest, it's kind of a rare thing, because narcissistic personality disorder, in addition to a person maybe suffering from other common diagnoses, that is more of a subtle multiple personality disorder, where there's all different types of narcissistic things that you would probably deal with when it comes to a person. But you would typically see, for an example, not to bring them up, but this is a true narcissistic case, was the president we had before now, Donald Trump. Where he's very grandiose. He felt like he could kind of do anything. He was untouchable. Right. So those are like the kind of things that you would see in a person, in addition to them being very sweet and genuine and kind. And then the next minute, maybe a trigger will happen and they'll get very upset and curse you out. So that's multiple personalities. I mean, they're all defined as different, specific ones, but that is like a kind of an undertone of people, functioning as having multiple personalities. So
that is very interesting, because I've never even heard it described like that.
Mm-hmm.
And I think especially when you're dealing with somebody, how popular is, not, I don't want to say popular, but how frequent in the community is narcissism? Because I think people throw that word out a lot, but we don't really understand what it means in our interpersonal relationship with people when we're dealing with the narcissist, and they don't know. And I do believe that's also caused by childhood trauma as well. Is that correct?
Yeah, childhood trauma also, it could be okay, so let's start off with how it can be caused. So it can be caused by, like you said, childhood trauma. It can also be from a mother and or father or guardian, possibly consistently. Well, so let's get this right. It's nothing wrong with consistently praising your child, being there for your child, but I feel there is a fine line with making sure that your child knows that you love them, that you're there for them, that that you're supportive, versus consistently
the pedestal,
putting them on this huge pedestal. Because that fine line, especially if that is how they know how to identify themselves, that is how, as they're getting older, that's how they would identify. And unfortunately, some guardians turn their children into narcissists. So that's like another way as well. So as time goes on, I mean, to be honest, like it varies of people that are could be narcissists, and you do hear it a lot. But I guess the biggest thing would be a person that really doesn't have empathy, that is very self-centered, a person that that's yeah, I mean, to me, like when I think of narcissistic, I think of those huge two characteristic traits, right? Because it's kind of like, you don't even, I'm crying in front of you, I'm explaining to you a situation that's near and dear, but you're only in it for your benefit, and you're only in it to see how could you capitalize on whatever the situation might be. And that could be relational, that could be, work situations, whatever it might be. The person is really a self-centered person. So
Let me ask this, Dominique. Well, first, let me just express it. I'm sorry, I can't change the fonts of the name while we're on. It's something that will have to be done before we type them in. So I was answering something unrelated to this. My question is, a person, whether it's schizophrenia, whether it's bipolar, where it's something that they had to, they needed medication for.
right.
Is it possible for them to operate in such a way, whether that's through therapy and getting a handle on things and doing, using the resources available to them to then get to the point where they find themselves coming away from that diagnosis, where they no longer need the medication and they come away with they're no longer identified with that diagnosis anymore? Is that a possibility?
It is a possibility, but it's very, very rare. Okay. Only reason why I say that is because schizophrenia is a diagnosis that can only be in remission. It cannot go away. Like if you're diagnosed with schizophrenia, I mean, it's you can't say, okay, well, I haven't had any signs and symptoms for about 5-6 months. I'm no longer schizophrenic. It could be in remission, and then something else would trigger it, and then next thing you know, then it's back. So I do, I have seen patients where they are just completely against wanting to take any medications, and they are schizophrenic, but unfortunately, they have triggers. And so when the triggers come about, it could be maybe a holiday, a relative that passed, a relationship, any type of stress. Then the schizophrenic, the symptoms, they just come about all of a sudden again. So a lot of times it is better in that type of diagnosis to make sure that the person is very, very, very consistent with their therapy sessions, that they are, even if it's just on a low dose of medication. Doesn't have to be a high dose, something just very low. And then also they have a type of therapy, because it's different types of therapy, but they have the therapy where they're starting to really recognize and see what their triggers are, and they can reflect and they can learn how to respond rather than
Right.
react. And that is a lot of therapy. That's not a once a month. That is a lot of times I recommend to start off, if you can, once a week, where you can really start to understand what the diagnosis is. Because some people are really scared. It's brand new to them. It's brand new to the family. No one knows how to treat it. So it's foreign. And then you already feel, like it's a stigma. And then you start to feel, kind of depressed for some people, because they're like, why me? Why do I have to be diagnosed with this? And so that is more therapy. And I always say the best way to treat is therapy with medication. So when it comes to a diagnosis like that, when it's schizophrenia, that, because like I said, it is in the line of being a psychotic disorder, that's completely different. Okay. But there are some people that, are on depression. That's a mood disorder. And that is where people can, be on, can start off with a medication, and then I would say you can slowly take them off of it. But that's not, at least the way I practice, that's not for at least almost to probably close to a year before I even think about wanting to start to titrate you off of a medication. Because
and let me just, I can give a personal anecdote. I take Prozac because of depression, anxiety, and I also take lorazepam for sleep, because a lot of times, because my mind is always racing, I can't sleep. So they gave me that as well. And I'm kind of like my clients. We take medication, we start feeling good, everything is great, I can do my work, I'm just living life, I'm talking to people, I'm having a great time. And I decide I don't need my medicine anymore. And it will be months, and I just won't take my medicine.
Yeah.
And I know I'm not taking my medicine, but I'm Cheryl Bailey. I can do this because, that's who I am. And then people be like, you're not singing at work anymore. And I'll be like, oh, I'm just feeling some kind of way. And then it just goes down and down
Yeah.
I'm going to talk to my therapist, and I was only having sessions every once a month. And she was like, based on what you're saying, I'm very close to calling the people on you.
Yeah.
And I'm thinking I'm fine.
Wow.
But my behavior has changed so much that people around me notice,
And
even before I notice.
Mm-hmm.
And it's the mistake of just stop. I'm just going to stop by myself. I'm not
the
going to.
hardest person to see is yourself.
Yeah.
That's the
Mhm.
hardest person to see. We got a
I'm
couple
the
of
hardest person.
Yeah.
Yes. And with my ego, I'm like,
Doesn't help. Yes.
over. Hey, now you get over into narcissism again. Now,
Oh,
the doctor said I'm not a narcissist. And my therapist said I'm not a narcissist. Close, but not there.
hey, someone asked about treatment options, and I want to just combine these two questions. Someone asked about some treatment options, and which
okay.
you've already addressed a lot of that. And in my line of work, I often encounter pregnant women who would go off of their mental health med due to the fear of harm to the baby. Can
Yes.
you address the safety and danger of this?
Oh yeah, absolutely. It's very, very, it's very dangerous, but at the same time, I feel it depends on the trimester as well, because I've had a few patients where I normally refer patients that are OBGYN to their OBGYN, to be honest. I mean, especially when they're in the beginning stages, if they're in their first trimester, um it is dangerous with certain medications. Okay, not all, but with certain medications, it is dangerous to give to a child, to take while you're pregnant during the first trimester. So if they're like on lithium, I'll just name one. It's a very common medication for bipolar, some for bipolar depression, or even for schizophrenia. And if a mother is trying to, if she's trying to conceive and she's in her early trimester, that can cause all different type of neurological deficits for the child if they're taking it during their first trimester. So you have to be very careful when it comes to certain medications. Yet, even though it is very dangerous, I do agree with you for them not to be on them maybe during their later stages, but during the beginning, there are always referred to OBGYN because there are certain medications that really could cause the child harm, and that they probably have to go off of it for maybe the first few months, and then afterwards, once they stabilize even medically and it's cleared, then they can kind of go back on medications, but at a different dose. So, or maybe I've seen that too, where I've taken care of pregnant women that are in later trimesters, probably like maybe their 6th or 7th month, and they're psychotic. They're floridly psychotic. And so I probably would start them on like maybe Haldol. I don't know if you've heard of Haldol, haloperidol, but that is a medication that's, it could be typically safe depending on how you dose it. And there's other ones out there, but always refer to OBGYN before say, hey, don't take this or always talk to the OBGYN. But once that's cleared and that's okay, then maybe during like the 2nd or 3rd trimester, you can slowly reintroduce the same medication but at a different dose. So I mean, if so that's for the pregnant, right? pregnant ladies. Yes.
I think it might be easier to address the treatment options if we start with the first thing. How do people get evaluated for mental health? Diagnosis, any diagnoses?
Sure. So there are several types of ways for a person to be evaluated. So you can be evaluated by a psychiatrist or a psychiatric nurse practitioner, and you're diagnosed, and treatment can start. But then I wanted to talk about also when a patient is very, very sick mentally, excuse me, how if you're at home and you have someone that's experiencing really symptoms that may even scare you, or to even leave the person alone, or even to be in their presence, whether it be they're talking to themselves, they're starting to exhibit bizarre behavior, there should be maybe uploaded, or we'll upload it in a little while, but there's some resources that I created for the audience that there's something called a psychiatric evaluation team. And so those are just licensed. It can be anyone that has a license to provide some type of mental health. So I've seen registered nurses be able to do it. I've also seen something called a MET team, where it's I believe it's called mental evaluation team or a medical evaluation team. But that's when it's normally like I've seen a police officer, also another, evaluator come in together. And that's normally if you call 911. So my suggestion is that if you feel that a person's behavior is not the way, and it's bizarre, it's not their typical behavior. Maybe they're starting to talk about things that are starting to, kind of put some thoughts in your mind, starting to scare you a little bit. Don't wait. Please don't wait, because that's when it typically goes a little bit further than what people anticipate. And then that's when a person goes from being treated as just outpatient basis, where you can talk to someone either over the phone or via Zoom, and their symptoms can, be lightweight controlled from that way, versus if they become completely psychotic, or they become suicidal, or they start to have different things that you can no longer see about controlling. They won't listen to you. Then that's when you have to call 911, and you have to get, other professionals that are able to, are licensed to able to deal with more critical mental health patients, in an inpatient setting.
Yeah.
So,
and Dominique, before you go forward, I always put this caveat in there as a criminal defense attorney. If you call 911, there is a possibility that the person you're trying to help can be hurt by the police and or charged with a crime. So one of the resources that she put in there is a PET team.
Yep, I put it in the comments.
Which is in the comments. And they are an emergency resource that you should probably try to call first, unless there's a risk to someone's life, or somebody's going to hurt themselves or someone else. So that's the kind of the criteria that when she's saying weird or abnormal behavior, the criteria that they use is whether somebody is a risk to themselves, risk at harming themselves or someone else, or unable to take care of themselves. Then you want to, number one, first call the PET team or any other emergency team that is not the police, and they're going to try to have more of those services. But if it comes to the point where you have to call the police, let them know this is a mental health situation.
Right.
And that the person is a threat to themselves.
Right.
And they're starting to be trained better. But just know that you want to not wait for it to be a 911 emergency type situation. You want to try to get help as soon as possible. Every county, every city has a Department of Mental Health that you can walk into, and they will give you a list of programs and services that you can take people to get assessed as well, like your kids, older adults, if they're willing. Yeah. So one of the things that I think Dominique is going to get into now is about inpatient, outpatient, all these things, a lot of times, unless they're being forced, are voluntary. Yeah. So even an outpatient, you can't make somebody go to outpatient. You can't make somebody go to inpatient unless they meet the criteria that they're harmful to themselves or someone else, and then they'll be placed on a hold to be evaluated. And so I'm sorry, I just wanted to make that very clear from a legal standpoint so that people are not just calling 911 all willy-nilly. Please do not do that. Someone can die. Yes. So make sure that if you call 911, that you're calling them because their person is a risk to themselves or someone else, not because they tearing up the house. You call a PET team, that's my opinion. So go ahead, Doctor.
Oh, no. And then also to add to that too, if a person is not able to, it's a term called gravely disabled, where if a person is not able to adequately provide a plan, a safe plan for themselves, they can be considered to be gravely disabled. So that's typically like a person that if they're coming in, they're elderly, or this is just an example. And let's just say if we they're coming in from, the streets, or maybe they live with you and they just decided to kind of wander off. We've seen that before. And, you're wondering where your relative is. It could be related to maybe a new onset of dementia, but this is just an example of them not being really able to, and maybe you're not the person that's their conservator or their power of attorney. But if this person, you consistently see that, wow, if I were to go to work and I were to leave this person alone, they could potentially, something can happen to them. And it's not because they necessarily are having the thoughts of wanting to, hurt themselves or other people, but they really are not consciously able to provide like an adequate plan. They cannot tell you whether or not, if they were to walk down the street, and they had a doctor's appointment, they wouldn't be able to make it to their doctor's appointment. They're not able to handle their own, money or finances. They're disheveled. They're not taking, baths. They're not eating. I mean, these are certain things that we look at as well that will put them in that classification of being gravely disabled. And that is another reason why someone will be placed on a hold as well too. So that's something else that, you can kind of like, start to kind of gauge into as well, because what happens is that, and this is touching base on, for guardians or family members, you end up, you're staying, let's just say if this is someone that you're trying to take care of, and you end up, kind of leading off into, and that's maybe something we could touch on another time, but it is important that caregiver burnout, that's something that you and I brought up, Cheryl, where you're taking care of someone, and it could be that they really have a mental health issue that is starting to weigh down on you. I mean, like I said, there's some resources that, are uploaded, but it's steps that you can take, preventative measures that you can take. And she's right, before calling 911, that is to the extreme, but you never want to leave yourself in danger or allow that person to be left in danger. Because one thing I know for sure, for the psychiatric evaluation team, you can call. Sometimes they take, sometimes 6 to 8 hours, sometimes even a whole day. It depends on how busy they are. But if that person, if it is where you see that they are dangerous, you can exercise other options. But it was something else I wanted to touch base on too. So talking about mainly some of the holds. So there's different holds that is pretty important. Maybe just the two common ones to touch base on. So there's kids that if a child is under 18 years old, there's a 50, there's a same thing, a 5150 hold, where the differences between the two is that let's say if someone signed in, that's voluntary. They're telling you, they're saying that and this is for over age 18 or over. They're saying that they're willing to come and seek psychiatric treatment. So you can also address your relative or family member, whoever it might be. Do you want to just go into the hospital, for a few days, just to maybe see how everything is going? It doesn't necessarily mean that they're going to put you on medication, but just at least start maybe therapy, right? Okay, right. That's one way you could approach it, and they can sign involuntary where they don't feel that it is because sometimes people don't really respond well under pressure, or if they feel that they're going to have to be medicated. And, like I said, it's such a stigma. They think of restraints and white jackets. They may not want to go. But if you introduce it in a way where you're saying, this is just, just to see for a couple of days, just to get another opinion of someone else, you can have them sign involuntary. And it just leaves a situation where it's more open and it's comfortable. Okay. But if you have a person, like I said, that meets the criteria for being gravely disabled, they're a danger to themselves, where that if you weren't around, they will probably try to literally maybe walk in front of traffic or do something harmful to themselves, or they've maybe tried to attack you or someone else. It could be unprovoked or provoked, but if it's dangerous, then that classifies as probably wanting to have that person, when they come to whatever, the emergency department or maybe just the hospital, you would want them to be more likely placed on an involuntary hold, because if they were voluntary, they're gonna, as soon as you leave as soon as you leave their presence, they're probably gonna sign out and leave and go home, or or God forbid, probably try to hurt themselves or maybe someone else. So that's something else too, just the differences between voluntary and involuntary. And one other thing as well too is that if you ever hear someone speaking of threatening someone else's life, we're mandated to report something called a Tarasoff report. So that's something else too that you guys could think about and take into consideration as well too. If you hear someone making a very dangerous threat, and it's been clear and defined that they suffer from a mental health issue. Doesn't have to be mental health, but just make sure that if there is along the lines of a mental health issue, and they are threatening someone's life, and they have a plan, and you've heard them say that, and you probably even know that they have even a weapon, you need to be calling the psychiatric evaluation team as well too, because it's very important. I see that commonly all the time, where this person has a plan to actually really hurt someone, and if they were discharged, that they will act upon that plan. So if you hear that, you should be calling the psychiatric evaluation team as well, because you don't want to be placed in a situation where, what if it actually happened and you overheard it, and you know that person probably a little bit better than any other mental health evaluator. Maybe they've
Right.
actually acted on it before, so why would you take the risk? So I would say it's always better safe than sorry. But there are several resources, especially on samhsa.gov, where for children, for just any type of, for detox treatment. Some people go through, dealing with detox with drugs or alcohol. You can always click on that website and type in your zip code, and they have programs. They actually have free programs. There's one that's called here it is, Whole Person Care. That is very, very helpful. I mean, that's just one resource, where they're paying for people that are homeless. They're paying for their housing. They're providing them with shelter and food.
Is that whole person care?
Whole Person Care. I put it in the
Oh,
resources
it's in the
too.
resources. Okay.
So that's just a few things to point out. It's so many levels of mental health, but it is very, it's a very it could be it could be easily, it could be preventative with a lot of different things before it gets out of hand in some cases. And then sometimes it's just, a person could honestly have a traumatic event that happened, and then next thing you know, they're completely psychotic, and it's hard to bring them back to where they were. So,
or just generally in crisis.
mm-hmm.
People can get into just a crisis mode, like the pandemic. We've all been, in a trauma for 2 years. And so a lot of things that we're seeing online, or a lot of the responses that we're seeing are trauma responses, and people are acting outside of their personality because we're literally living in a crisis. There are also 2 other questions in the chat. Pastor Hosea, do you want to try to answer them before we have to log off?
Yeah, because we're actually out of time, but we're going to try to address them quickly. And I'm going to update the chat with the mental health, with our email, that you can always email any questions that you may have here, and we can address them at the top of our next session. I'll read them very quickly. Is there an identifying sign we can look for to quickly separate one behavior from the next? I think that's kind of what you got into when you were breaking out the differences. But it sounds like a professional will really have to be the one. But that's one question. And the next is, how can you? I don't really understand this one, but I'm going to read it. How can you, the partner or spouses, in types of an illness in a relationship, relational past the danger, but day to day? I think they were typing kind of fast and left out some key words. But the first question was, how would you identify one sign from the next?
Okay. So that all goes to, what type of diagnosis you're speaking of. But as far as the danger, um, there's something that I recommend everyone, a class that everyone to take. It's probably, for some, it's probably like maybe a 4 or 5 hour course. They may even have it online, but it's called a CPI. It's called Crisis Prevention Intervention. Also, it's another one called MAB. Um, so what these courses are is basically it talks about the signs and symptoms of how a person, family member, whoever it might be, you start to see the accelerating signs. That's what I would consider to be the almost danger sign, right? So their fists are, clenching, their voices, could be raising, their eyes could kind of get, very bold, their voice becomes extremely, elevated, they start to impose. That's like nonverbal signs of threatening behavior, where if a person is starting to act that way, then, you don't necessarily ever want to be, especially if they have a history of being that way. You never want to be caught when you're in a room and that person's back is towards the door. You want to be the person where your back is at the door and they're in front of you, if that makes sense. Because if they start to respond in a way that is very threatening or possibly combative, you can back away from that situation where you're exiting. You have an exit, okay? Because it's very dangerous to be caught in a situation where, if that was the opposite way, if you can visualize it, where you're the person that is on the opposite side and they're blocking the door, if you're trying to get out and they start to impose threatening behavior, where you gonna go? They're right in front of you. Where you gonna go?
Right.
So that's like one thing, as far as the harmful aspect. Now, when it comes to the depressive, possible, suicidal aspect, you start to hear things where they start to become hopeless, where they start to voice things like, well, I don't know if, life is worth living anymore, or, maybe I'll just be better off not even being here. They start to say
Or
things.
everyone else will be better off without
Yeah,
them there.
everybody will be better off, or they start to give away their clothes. Just different behavior. They start to talk about or sometimes they become extremely happy all of a sudden out of the blue, when they were, maybe suffering from depression. And a lot of times it's because they've already made up their mind that they're going to commit suicide. So they're happy and elated over the fact that, my life is going to end. Like, this is no more. I'm glad. I'm happy. So, and then maybe they start to discuss old memories with you consistently. And this is all a collective, thing of behavior. It's not just one after the other, right? But
Right.
this is all a collection of just like their behaviors, where you start to question, okay, is this person, really depressed? And if they are possibly suicidal, especially if they mention, and that's the key factor, if they mention something about suicide and you start to see all those other behaviors after a while, and if you're lucky, okay, and I say that really meaning that, because this is the highest suicide rate that we've had ever because of the pandemic in 2021. So
Wow.
you may
Wow.
you may or may not, experience hearing them wanting to hurt themselves. They may just actually say, I love you, you're awesome, you're the best whoever in the world, and then the next thing you know, they have, actually committed suicide. So you have to pay attention to the biggest thing I would say to answer the question is to what is off. Follow your gut. You know, we don't have, God didn't give us that intuition just because. It is a God-given intuition that you have. And I follow that every day that I practice. Every day. It's not just, just clinical textbook. I also follow my intuition. So if you know that this person normally maybe a happy-go-lucky person, or maybe they may be a crabby person, who knows? If it's something off, follow that. Start to really follow that and ask questions. Ask questions. But yeah, I mean, you typically, if you're really intuitive as well too, and you can pray for discernment, you'll be able to start to see certain signs and certain things that make you say, okay, you know what, I need to start really paying a little bit closer attention to this person. So, I mean, that's what I would say about that.
I want to, because we are out of time, but everybody, they flooding us now with questions. I'm doing these 3 more.
Yeah, Ryan's question, I just want to make sure it definitely gets answered.
Okay. This one right here. How does a person know if they need to seek help? The person themselves. Like if it's you yourself. If it's me, how do I know I might need some help? Is there a way I can kind of self-diagnose that I need to get checked out?
Yeah, I mean, if you know, just like how you were mentioned earlier, Cheryl, you started to see those signs where you're like, hey, I mean, or you could be sometimes in self-denial, right? But if you really, typically it's, if your normal behaviors are consistent, and like I said, it depends on the diagnosis. So if you're depressed, and everybody goes through that. Everybody goes through a mild depression every now and then. I don't care who you are, you have been through it before. So, but if you notice that it's consistent, let's just start with there. The most, common diagnosis, if it's consistent, if your energy levels are, decreased, your concentration, your focus, you start to have negative thoughts all the time, no matter what. It could have been the best day of your life. You could have got a huge, raise and kids, got saved, everything. It doesn't matter. You're still always having pessimistic thoughts. Those are like starting to be like symptoms of signs. Maybe you're not eating like you would, appetite increased or decreased. It could be your sleep. You start to develop insomnia. You or maybe you're sleeping, oversleeping. It could be those things. Those are just like some of the symptoms of depression where you do need to seek help. And it doesn't necessarily have to be medication right away, but at the bare minimum, you should be having some type of counseling, at least maybe once a month.
That's good. In a relationship, how do I support my spouse or my significant other who's dealing with mental health issues on a day-to-day? How do I support them day-to-day? And then that's the second to the last question.
So yeah, sure. So day-to-day, first and foremost, you should be really seeking God. You should be asking the Lord to guide you and to really help you, because you can't do it by yourself. I don't care if you take them to 5-6 different specialists. You really do need that foundation. So that's the first thing. You should be really seeking the Lord. The second thing is that so you said that how do you know if you want, what was the question again? How do you know if you want?
I'm married.
How do you support somebody?
How do you support somebody?
How do I support them on a day-to-day basis?
Okay, so other than praying for them, like I said, I would talk to them openly about how do they feel about counseling. How do they feel about that? Because if you hear for the basics of they don't feel comfortable whatsoever to do counseling, then a lot of times they're not going to be that open to medication, right? But first ask them, how do you feel about counseling? What if I go with you? Would you be okay with that? Is that something that you will feel comfortable with? Because sometimes if you go, I notice that when two people are together, and it just maybe just because they were so scared of what the outcome might be, then maybe 1 or 2 sessions after that, then they can start being alone in their session. So that can be, it's not like you're dragging them. I don't like to use that terminology, but you're being so supportive where you're present. And that's what they need, is your presence first and foremost. And then afterwards, sometimes it's a fear. After they, kind of overcome that, then they can start going by themselves. Another thing is I like to call it, I tell people this, to do a 5-minute powwow every day, and that's basically no distractions, no, no cell phone, no social media, none of that, no TV, just you and that person. And you maybe can be forthcoming about telling that person how was your day or how you're feeling, and just being completely organic about how, what's going on in your life. It could be something random, right? But that's to open up their mind, their heart, their ears to start to tell you about how they feel. And mind you, when they do, try your hardest to, even if it's something that you don't really want to hear, the last thing you want to do is have that person close off about them being completely organic with you. Okay. So, you don't, oh, my device is running low. You don't, my battery, you don't want to be judgmental. And that is a lot of times through your facial expressions, and which a lot of people, even sometimes even myself, have to work on. Your facial expressions. What else? You being, making a comment back to what they're making a comment back to what they're actually saying. Just let them speak, let them talk.
Oops.
That's the device.
Yeah. And I think believe them. Believe people when they say how they feel, and don't belittle them. Like, yes, everything's fine, and I still feel like the world is ending. So just believe them, be there, and take what they're saying seriously. And then I think, are we going to answer Ryan's question?
Yeah, he's been getting some feedback already, but I'm going to.
It's really a legal issue too, Ryan.
Okay.
So you have to. The law says you have to make the request.
You can't see it.
Huh?
Let me read it for the people that are on that platform. I think my daughter might have Dominique is back. Let me read it with her on. Okay, Dominique, I'm going to read this last question.
Okay.
And Cheryl's going to tackle it from a legal perspective, and then you can tackle it from a clinical perspective. He says, I think my daughter might have ADHD only because she makes F's in the 6th grade and her inability to follow directions at home. How do I go about getting her evaluated? Cheryl.
Okay, so I used to practice a little bit of education law. So there's a legal way to do this. You need to write a letter to the school district and give it to the principal in writing. And there are a lot of laws. They have like 10 days to do an assessment. I think it's 30 days to do an assessment. And it could be more than just ADHD. There are a lot of different learning disabilities. My niece has dyslexia. So number one, do a letter to the school district in writing requesting a formal IEP, that's an individualized education plan, and assessment for special education or special needs. They have 30 days to respond and to set up the appointments for the assessments. It may be a little bit different because of COVID. They'll probably be online. It's a battery of tests that they will give her to determine if she has disabilities in a very wide variety of situations, because it could be a lot more than just ADHD. After the assessment, they're required to have an individualized education meeting plan with you to go over all the assessments. Make sure they do this, because sometimes they don't. They just have a parent sign it. Make sure they do this. Look at all the tests and range and ask a lot of questions. And then if they do find that she is disabled or needs special help in any of those areas, they have a certain amount of days before they set up the classes that she needs. And they're supposed to keep her in her general classes and just pull her out for, it's a lot of legal rules to it. But you can Google it. So just Google California Individualized Education Plan assessments and letter, and they'll have the letter that you send to the school district, and it'll help you get on your way. And then you
also again, California Individualized
Education Plan.
Okay.
And then just type the word letter behind it. And then it should have the copy letter with the dates and the times and all the things. Make sure the letter has your child's name and birth date. Okay, sorry.
I got you. Got you.
All right.
All right.
No.
Okay, Dominique, again, I think my daughter might have ADHD only because she makes F's in the 6th grade and her inability to follow directions at home. How do I go about getting her evaluated?
Okay, another way you can do is you can go to the they should have, although that's the college campus, but they should have like a, to touch base on what you were saying, Cheryl, where they have it's like I think it's, would it be considered as like disability, like an office where they have the testing and your child can test. I know this because for a fact I suffer from dyslexia. So when I was in college, and mind you, I know that she's probably about 12 or 13 years old, I would say, maybe 11 or 12 years old, but they should have the resources on the at her school where if, let's just say, if it is dyslexia or if it is ADHD, I mean, it could even be depression, because that even sounds like depression as well, especially with a child that may or may not be performing the way that they possibly should be or could or should, in the past have been performing in school. It could be an underlying depression too. But if they do have, they should have it available. You can get her tested at school and just say, I want to test for possibly, a mental health disorder, whether it's dyslexia. Let them determine it. Once they test her, they do have available. And like I said, I even took advantage of this because I suffered from dyslexia, where they give you double time on your test. They give you a private room or private space where you can do your testing, where maybe I know that's what it was for me at times, where I couldn't be distracted. Like you have to be, in a setting by yourself, double time, where she's able to possibly read over maybe the questions and the answers more thoroughly, because she probably does get really distracted when there's other kids around, popping their stuff on the desk and gum or tapping their feet. Those things like that really could be a detriment to someone's workload when they're trying to concentrate and focus. So I would go and I would just ask what resources they have, and the words that you would ask, you would just say for a mental health, you could say dyslexia or ADHD. I just want to figure out what resources that you guys have available here at school for me to for my daughter when she's testing, what is available for her. So that's one thing that you can do in addition to if she is open to talking to a therapist, because like I said, it could be parents typically think that it's ADHD, but it could be, like I said, an underlying depression that maybe something that she dealt with that you may or may not know, but a therapist will be able to be able to get down to kind of like the nitty gritty of what's really going on, why is she performing that way.
Yeah. And just for there's also the Public Counsel Children's Rights Clinic. It provides free legal services to help you with the letters and everything if you don't want to do it yourself, and also Alliance for Children's Rights. So Public Counsel Children's Rights Clinic and Alliance for Children's Rights are two organizations that will help you do a lot of things with your kids, especially with the school district, and trying to determine if they need resources or special. So Public Counsel Children's Rights Clinic, and then Alliance for Children's Rights are two organizations that will help as well with the legal side.
Amen. Well, y'all listen, everything that was spoken, we have it in the chat box. So please check it out. Take advantage of these resources. Thank you so much, everybody, for joining us. This has been so informative. I pray that you even taking notes, because we're going to have to come back again in the future and revisit this. This has been awesome. So at this time, we're going to have closing remarks from Cheryl, closing remarks from Dominique, and we're going to be out.
Thank you guys for listening, and really listen to yourself. Listen to the people around you. If people are saying something isn't right, if you're just feeling walking around in a cloud and you just feel something isn't right, it doesn't hurt to just make a call. If you have insurance, they always have a medical professional that's willing to talk to you, even on an emergency basis, to just say, hey, I just need to have a conversation to make sure I'm okay. And there's nothing wrong with it. I take medication. I go to therapy every other week, sometimes twice, when the doctor is like, no, I need to see you again. And it's really made my life manageable because, as my friend told me, you do not have to suffer. God did not make us to suffer. God did not create us to suffer. Nowhere in the Bible says you must suffer and suffer more abundantly. That's not what it says. It says he came to give you life and life more abundantly. So in order to have life, you have to take care of your life, which is your mind, your body, and your soul.
Amen.
Amen.
Good. Well
Yeah.
said.
Yeah. So I thank you guys so much for having me, and really just continue to pray. I mean, we're in a season now where the church is fasting. Hopefully you're participating in that. But I strongly recommend that, when you are, you like Cheryl said, you have to listen to that sixth sense that we have. It is your gut. That is the Holy Spirit within you really trying to talk to you. Don't ignore that. Okay. It's okay to, have kind of go back and forth, but don't ignore, what the Holy Spirit is trying to tell you. Okay. The resources, hopefully they'll be helpful to you guys. And also one other thing I wanted to add with I should have added to the resources is for some that may or may not have insurance. Do not let that discourage you because there are free mental health resources. Also, you can sign up for something called medical financial assistance if you are in a urgent care or emergency department where you get a year of free insurance. Okay. 1 year of free insurance. Okay. So that's something just to remember because that is when people get discouraged because of the insurance reasons, you can still take care of your mental health. They have free resources. Okay. But don't wait. Don't wait. It's better to, consistently have it going and do it rather than waiting to the last minute. Just do it. Okay. But that's it.
So good. So you guys, you heard this. I think I want to commend these two panelists for being so open and transparent because you're talking about two successful, intelligent, professional women that have both admitted that they deal with their issues. Like Cheryl, she admitted to you, here she is a defense attorney standing representing people before judges every day. And she's dealing with her mental health. She's on medication and she's not ashamed. So let's remove the stigma. You hear Dominique, a professional practicing nurse practitioner, telling you she deals with dyslexia. With all of her education, she had to go through dealing with that as through the lenses or dealing with the filter of dyslexia. I myself, as a pastor who counsel people every week and sharing other people, building them up, I myself had to go through therapy. There's nothing wrong with seeking help. You're not weak because you seek help. It means you're strong. You're strong enough to do what's necessary for you. And what's necessary is never unwise.
Amen.
God bless you. Till the next time, that is our time, because we're out of time. See you next time. Take care.